Let's talk about shoulder joint now. Yeah, so shoulder joint or glenohumeral joint. This is the glenoid cavity of the scapula and this is the humerus. So shoulder joint, otherwise called glenohumeral joint. It is the one of the most mobile joint in our body. That means that enjoy the maximum degree of freedom. Always the freedom comes at the cost of the stability. So this is the one of the least support, least stable joint. There are so many mechanisms in our body to maintain the stability of the shoulder joint by the muscular factor, ligamentous factor, and many other factors. Okay, so see the disproportionate size of the glenoid cavity and the head of the humerus. So here itself you can see how loose and lack will be the shoulder joint capsule and how this is going to be maintained in a functional integrity will be a question, right? So let's talk about that now. So it's a ball and socket type of synovial joint. It's a synovial joint of ball and socket type. There's a ball, there's a socket. Socket is formed by the glenoid cavity of the scapula, which is located at the superior lateral angle or lateral angle of the scapula, which is a pyriform shaped shallow depression. Whereas the head of the humerus, this is the head of the humerus, make the ball. It makes a one third of a big sphere. Okay, so this makes the ball and this make the socket. Hence, it is a ball and socket type of synovial joint. Okay, your hip joint is also an example for the ball and socket type of synovial joint. The head of the femur articulate with the acetabulum of the hip bone to form another so ball and socket type of synovial joint. That joint is very strong and stable, unlike the shoulder joint, which is least stable but enjoy large degree of freedom. So let's talk about the articular surfaces. As as already seen, the articular surface is made by the shallow glenoid cavity on the scapular aspect, which is covered by hyaline cartilage. Hyaline cartilage will be thin in the center, but it will become thicker as it goes towards the peripheral aspect of the glenoid cavity. The same way, the head of the humerus make the other articular area, which is also covered by articular cartilage. That will be thick in the center. As we go from center to periphery, it become thinner. Okay, and it is covered by a fibrous capsule. So let's talk a bit about the head of the humerus. This is the head of the humerus, which is covered by hyaline cartilage and which take part in the formation of the shoulder joint along with the glenoid cavity of the scapula. Now, this area where the head of the humerus meet with the remaining part of the upper end, this is the anatomical neck of the humerus. Anatomical neck of the humerus. Okay, and the upper end again presents two more big bony features here. This is the greater tubercle. Greater tubercle give insertion to infraspinatus teres minor. The above downwards, teres minor, infraspinatus, and the uppermost for the supraspinatus. So above downwards, supraspinatus, infraspinatus, and teres minor is inserting into the greater tubercle. And here, this is the lesser tubercle, which get the insertion of the subscapularis muscle. And in between the greater and lesser tubercle, we have an elongated bony groove here, which is called as the intertubercular sulcus, otherwise called bicipital groove, because the long tendon of the biceps travels through this channel with a covering of synovial membrane around it. Okay, and the lateral lip of this channel give insertion to the pectoralis major. The medial lip get the insertion of the teres major. On the floor of this area, get the insertion of the latissimus dorsi. Now let's talk about the fibrous capsule, synovial membrane, and all. So let's see, come back here. The fibrous capsule is attached onto the peripheral margin of the glenoid cavity outside a fibrocartilaginous rim on the glenoid cavity called as glenoid labrum. See, this is a very shallow space. In order to make it a bit more deeper, a rim of fibrocartilage is kept or set around the peripheral aspect of the glenoid cavity, what is called as the glenoid labrum. The function of which is to increase the depth. So our glenoid, the capsule of the shoulder joint is attached along the peripheral margin of the glenoid cavity outside the glenoid labrum, except in the uppermost portion. Uppermost portion, we know that there's a small tubercle called as the supraglenoid tubercle, which give origin to long head of the biceps, long head of biceps, which runs almost anterior to the head of the humerus when the arm is on the side of the body. When the arm is laterally rotated, is exactly go above the head of the humerus. So what happens? It's a factor which can prevent the upward dislocation of the head of the humerus from the glenoid cavity. Okay, so our fibrous capsule is attached along the peripheral margin of the glenoid cavity outside the glenoid labrum. Okay, now coming to the humeral aspect. It is attached along the anatomical neck of the humerus. So this constriction between the head and the remaining part of the upper end. This is called anatomical neck of the humerus. Here, the fibrous capsule is attached along the anatomical neck, except there are few deficiency here. In the region of the bicipital groove, the fibrous capsule attachment is deficient. That means it is not the. In order to get the passage for the long head of the biceps to come out of the shoulder joint. Remember, the long head of the biceps, which takes origin from the supraglenoid tubercle, has got a intracapsular origin. It takes a journey within the capsule anterior to the head of the humerus and enters into the bicipital groove, piercing the fibrous capsule. Okay. One more peculiarity is that on the infromedial aspect of the neck, the shoulder joint capsule is sinks around 1 centimeter, dips for 1 centimeter to get attachment over the surface of the humerus. That means not exactly onto the anatomical neck. It descends downwards for 1 centimeter and get attachment over like this. So what happens? The capsule become loose and lax. That provide the mobility for the shoulder joint. Yeah. So this is the fibrous capsule, which extended from the scapula towards the anatomical neck of the humerus. This is called as a transverse humeral ligament, which bridging the intertubercular sulcus, under which we have this. This is the long head of the biceps covered by a synovial membrane. Other things, what all thing you are seeing here. This is the coracoid process. This is the acromion process. So what can we call it as coracoacromial ligament? Coracoacromial ligament. So coracoid process, coracoacromial ligament, and the acromion process together called as the coracoacromial arch. Coracoacromial arch. Okay, so underneath this coracoacromial arch, the passage of the supraspinatus tendon on its way towards the greater tubercle will be lying. So underneath this ligament, passes the supraspinatus muscle towards its insertion to the uppermost impression on the greater tubercle. So there's a chance for the tendon to get rubbed against the unyielding fibrous ligament. So that may cause injury to the ligament. So in order to prevent this, there is a bursa located between the tendon of the supraspinatus and the coracoacromial ligament. This bursa is called as the subacromial bursa. Subacromial bursa, which is the largest bursa in our body. Okay, so you can see this coracoacromial arch prevent the upward dislocation of the head of the humerus when it is tends to move up. Okay, again this subacromial bursa act as a secondary joint, what you call joint, support for the joint from above. So let's talk about the capsule. And another thing we'll be seeing here is a rotator cuff. What do you mean by rotator cuff? You know that the four small muscles which are rising from the scapula and inserting onto the greater or lesser tubercle of the humerus are the subscapularis, taking origin from the subscapular fossa and inserting onto the lesser tubercle, and the supraspinatus, infraspinatus, and teres minor, which are getting attached onto the upper, middle, and lower impression on the greater tubercle. These four muscles, when they coming towards the insertion, they get flattened. The tendon of these muscles get flattened and they fuse with each other and partly fuses with the shoulder joint capsule. This is called as rotator cuff. Rotator cuff. What it does, what do you call it? It helps to retain the head in close contact with the glenoid cavity. The function of which is maintaining the close proximity of the head of the humerus to the glenoid cavity is the function of the rotator cuff. So it helps in the increasing the stability of the shoulder joint. Clear? Glenohumeral ligament. The name itself is telling you glenohumeral ligament. From the glenoid cavity towards the humerus. So there are three ligaments, upper, middle, and lower. We'll come to that when it comes. When a little more detail, I'll show you the diagram and then I'll talk about it. Okay. Deeper to fibrous capsule. In any synovial joint, there is a serous membrane called as synovial membrane, which covers the intracapsular part of the articulating bone as well as the inner aspect of the fibrous capsule. But it stops at the point where the hyaline cartilage or articular cartilage starts. It ceases when the cartilage starts. That is the general pattern of arrangement of the synovial membrane. It covers the inner aspect of the fibrous capsule and giving a glistening appearance for the inner surface of the fibrous capsule. And it covers the intracapsular part of the articulating bone but stops where the point the hyaline cartilage starts. Clear? The synovial membrane produces a fluid called synovial fluid, which prevents the rubbing or friction between the articulating bone. And also it gives the nourishment for the articular cartilage, which is otherwise avascular. Yeah, let's go a little more detail will come for the one by one structures in the shoulder joint. So as I told you earlier, the glenoid cavity is deepened by a rim of fibrocartilage called as glenoid labrum, which is triangular on cross section. Okay. Sometimes this glenoid labrum may deficient or partly what you call not very prominent in the anterior aspect. So what happens? There's a chance for the anterior dislocation of the shoulder joint from the glenoid cavity. It simply slips into more medial aspect lying below the coracoid process. So that condition is called subcoracoid position of the humerus. It is called the dislocation of the head of the humerus in subcoracoid position. Sometimes it happens when this glenoid labrum is partly deficient in the anterior aspect. Coracohumeral ligament from the coracoid process to humeral process. Okay. So from the lateral border of the coracoid process to the anatomical neck, there's a ligament called as the coracohumeral ligaments. Okay. Then transverse humeral ligament is nothing but a band of fibrous tissue which bridging across the intertubercular sulcus to keep the tendon of the biceps within space. Another ligament we will be seeing here is the glenohumeral ligament. All these ligaments are nothing but the thickening of the fibrous capsule to impart an extra support for the capsule. So there are three ligaments connecting the scapula to the humerus. They are called superior, middle, and inferior glenohumeral ligament. Here comes the superior glenohumeral ligament. Okay, this is the middle glenohumeral ligament, superior, middle, and the inferior glenohumeral ligament. So the superior and the middle glenohumeral ligament, all the glenohumeral ligaments are attached to the for the coracoid process and they diverge as they come towards the humerus. The upper attaches to the upper part of the lesser tubercle. The middle one attaches to the lower part of the lesser tubercle and the inferior attaches to the anatomical neck of the humerus. So this is the strong ligaments which keeping the contact between the head of the humerus and the scapula together by acting as a thickening of the capsule. Right? So here comes superior, middle, and the inferior glenohumerus. Superior go to the upper impression, middle go to the lower impression of the tubercle, and the inferior go to the lower part of the anatomical neck of the humerus. Okay, this is the acromion process. This is the lateral end of the clavicle. Here we have a synovial joint called as the acromioclavicular joint, which is a plain synovial joint which allow the movement of the clavicle during the movement of the shoulder girdle. Okay, so your movement of the humerus in the shoulder movement, for example, in the case of abduction of the arm, you can raise your arm up to 180 degree. Out of this 180 degree, 120 degree happens by the movement of the humerus in the shoulder joint, whereas the rest 60 degree is happening due to the movement of the scapula at the acromioclavicular and the sternoclavicular joints. Clear? So the movement of the humerus, the abduction of the humerus cannot be completely given the credit for the humerus, but it's partly done by the scapula also at the acromioclavicular and the sternoclavicular joint. We'll come to that. So I told you this whitish thing what you're seeing is this is the glenoid labrum. This is the pyriform shaped shallow impression called as the shallow space called as the glenoid cavity. Peripheral margin of it is getting or fitted by a fibrocartilage rim called as the glenoid labrum. Okay. Now, because of the disproportionate size of the head of the humerus and the glenoid cavity and the loose and lack joint capsule, the stability of the shoulder joint is also always at a risk. In order to make it more stable, there are some mechanism in our body. Let's see one by one. Supraspinatus tendon. When the see when the head of the humerus tends to slip downwards, that will be prevented by the upper part of the fibrous capsule. When then at that point get strained naturally. When this is coming downwards, the upper part of the capsule become out. Same way, the supraspinatus tendon also prevent the downward dislocation of the head of the humerus. Another is coracohumeral ligament, which prevent the downward dislocation. So these three things, supraspinatus tendon, tension of the upper part of the capsule, and the coracohumeral ligament, which is coming from the coracoid to the humerus. So when the humerus is slipped downward, that prevents the downward dislocation. It prevents the downward displacement of the head of the humerus, isn't it? Because of the mechanical reason, when the head of the humerus tends to go down, that will be prevented by a ligament extending from the coracoid to coracoid to the humerus. The same way, when the head of the humerus tend to descend downward, the supraspinatus muscle, which is inserting at the upper impression on the greater tubercle of the humerus, will prevent the downward dislocation, downward displacement. Same case with the upper part of the fibrous capsule. Now, the long head of the triceps and teres major, the inferior aspect of the shoulder joint is the least supported area. Here, we have only two muscles to support, no other ligaments here. The two muscles means the long head of the triceps, which taking origin from this point. What is this point? Infraglenoid tubercle, from where the long head of the triceps taking origin. That will run downwards and laterally towards the posterior aspect of the arm, where it meet with the lateral and the medial head of the triceps to form the tendon of triceps and inserting onto the ulna. Coronal inserting onto the olecranon process of the ulna, posterior part of the upper surface of the olecranon process of the ulna. So when it is when the head of the humerus tend to descend downwards, that is to a certain extent is prevented by the a muscle which is located in the inferior aspect of the shoulder joint. That means the long head of the triceps. Similar way, from the lower part of the lateral border of the scapula, we have a muscle going upwards and laterally in this manner. What is that? That is the teres major. So that also helps to a certain extent to prevent the downward dislocation. The glenoid labrum deepens the socket we have already discussed. The long head of the biceps, here comes the long head of the biceps. When the arm is located on the side of the body, that means in normal position and in the pendant position, the biceps tendon, which is taking origin from the supraglenoid tubercle, take a course within the fibrous capsule, run in front of the head of the humerus, as you are seeing in this diagram. Then enters into the and pierce the fibrous capsule and enters into the intertubercular sulcus. When the arm is rotated laterally, it assumes exactly go and located over the head of the humerus. In that case, it prevents the upward displacement. Same fashion, here this is the coracoid process, this is the acromial process. Here this is the coracoacromial ligament, altogether making the coracoacromial arch. So that is definitely going to prevent the upward dislocation of the head of the humerus. Underneath the coracoacromial arch, we have a bursa. What do we call it as? Subacromial bursa. Subacromial bursa, which is the largest of the bursae in our body, which act as a secondary socket for the shoulder joint. When this is the original socket, glenoid cavity, when it is moved upward in an accidental manner, that will be received by the subacromial bursa, which is located underneath this ligament. Hence, it is called as the secondary socket. Okay? Yeah, subacromial bursa, coracoacromial arch. Musculotendinous cuff, otherwise called rotator cuff, which is a joint effort by the four muscles which are arising from the scapula and inserting into either into greater or lesser tubercles. Okay, so naturally when they contract, they try to pull the humerus to the maximum extent towards the scapula. So what are these muscles? Supraspinatus, infraspinatus, teres minor, and subscapularis. Towards their insertion, they get the individual tendons get flattened and they unite with each other to form a continuous structure, and they partly get fusing with the shoulder joint capsule. Thereby, it prevents the separation of the head of the humerus from the glenoid cavity, thereby it increasing the stability of the shoulder joint. Okay, this is the diagram which showing the journey of the tendon of the long head of the biceps above the head of the humerus in lateral rotated condition and descend downwards. So naturally this is going to prevent the upward dislocation. Clear? Now coming to the relations. When you are done the dissection, you might have seen we cleared the everything in the axilla first. We cut all the blood vessels, all the branches of the brachial plexus. Then you saw this wide muscle called as the subscapularis, which filling the subscapular fossa and inserting into the the lesser tubercle of the humerus. This muscle makes the anti-relation along with the two muscle taking origin from the coracoid process. What are they? Short head of the biceps and the coracobrachialis muscle. So this is the anterior relation, coracobrachialis and short head of the biceps along with subscapularis muscle. The relation on the posterior aspect, this is the intact picture, the view from the behind, view from the posterior view of the shoulder joint before cutting all the muscles. So what all thing we have? The entire area, all the area below the spine on the dorsal surface of the scapula is monopolized by the infraspinatus. So this complete chunk is the from here to here. This chunk is the infraspinatus. And here you can see a small muscle here from here to here. This is the teres minor, which takes origin from the upper two-third of the lateral border of the scapula on its dorsal aspect. So naturally this is going to be the posterior relation of the shoulder joint. What are they? Infraspinatus and the teres minor. The superior relation. Yeah, here this is the head of the humerus. Over the head of the humerus, we have the tendon of the supraspinatus goes. Over that subacromial bursa, over that coracoacromial arch. Okay. So here you can see this is the supraspinatus muscle pass underneath the coracoacromial arch. The other view will be like this. The view from the front. This is the view from the back. This is supraspinatus tendon passing underneath the coracoacromial arch, separated by a bursa. That bursa is the subacromial bursa. Over the subacromial bursa, you have the coracoacromial arch. So above downwards, we have the coracoacromial arch, subacromial bursa, and the tendon of the supraspinatus muscle. Here, inferior relation, what is there in below it? We have two things here. The quadrangular space. Teres minor anyway makes the posterior relation. Okay, below it, here, this space. This is the surgical neck of the humerus. Okay, here, this is the long head of the triceps. This is the teres major. This is surgical neck of the humerus. So this is your quadrangular space. Teres minor above, teres major below, long head of the triceps medially, and the surgical neck of the humerus laterally. This space is called as the quadrangular space. Quadrangular space located inferior to the shoulder joint. So we have teres major, long head of triceps, axillary nerve, and the posterior circumflex humeral artery makes the inferior relation. The axillary nerve and the posterior circumflex humeral artery are the contents of the quadrangular space. Then the long head of triceps and teres major. So this is the posterior relation. Clear? This is the same diagram in a schematic way. You can see here what all thing you have already seen: supraspinatus, subacromial bursa, coracoacromial arch. Okay, and here you have the infraspinatus teres minor making the posterior relation. Outer to it, complete outer to it, there will be deltoid muscle. Deltoid taking origin from the acromion process. Below, you have the teres major and long head of the triceps with axillary nerve and the posterior circumflex humeral artery. Clear? You need to practice this diagram. Anteriorly subscapularis. There are some bursae around the joint. The idea of the bursae is to reduce the friction between two structures. Typically, when a tendon crosses any bony area or crosses any joint, there is a tendency for the tendon to rub against these unyielding bony structures and cause injury for the tendons. In order to prevent it, there are synovial closed bags called bursae are located. It may not be between the ligaments and the bony portion. It may there between the skin and the bone. It can be between the two tendons, or it can be between the any bony portion, any muscular tendon, anywhere. Wherever there's a tendency for the friction, there will be a bursa. We already talked about the subscapular bursa and the synovial sheath around the long head of the biceps, which prevent the rubbing of this tendon on the wall or floor of the bicipital groove. Subacromial bursa is done in infraspinatus bursa. There's a bursa between the shoulder capsule as well as between the subscapularis muscle also. Sometimes there will be a small deficiency or small cavity in the fibrous capsule, which allow the continuity of the bursa underneath the subscapularis to open into the shoulder joint capsule. Open joint cavity, directly opening into the shoulder joint cavity. That means the bursa become continuous with the shoulder joint cavity. through a small opening in the anterior aspect of the fibrous capsule. The subacro the bursa underneath the subscapularis may get continuity with the joint cavity. There's a bursa between the capsule and the infraspinatus also. Then above the acromion process and the skin, there's an bursa between the capsule and coracoid process. There's a bursa behind the coracobrachialis. There's a bursa between the teres major and long triceps, sometimes seen a bursa in front and behind the tendons or latissimus dorsi. Is also a location for the bursa to develop. Arterial subplates are copiously supplied by blood vessels by the anterior circumflex humeral artery, posterior circumflex humeral artery, which make an anastomotic necklace over the surgical neck of the humerus. And the suprascapular artery. Suprascapular artery is a branch of the thyrocervical trunk. Thyrocervical trunk is a branch of the first part of the subclavian artery. Nerve supply, it is also supplied by three nerves. The axillary nerve, which is winding around the surgical neck of the humerus, this portion supplies the lower and anterior part. Suprascapular nerve supplies the upper and posterior part. Suprascapular nerve passes through the suprascapular notch and then passes through the glenohumeral notch. Then it reaches the infraspinous fossa where it supplies the infraspinatus muscle. That at a time it supplies the give a articular fiber to the shoulder joint. And upper and anterior part is supplied by the lateral pectoral nerve. While doing the dissection of the pectoral region, you have seen the lateral pectoral nerve. Lateral pectoral nerve is a branch of lateral cord of the brachial plexus. Suprascapular nerve is a branch of the upper trunk of the brachial plexus. Erb's point, do you remember the Erb point? Erb's point is the upper trunk of the brachial plexus where six nerves are meeting. Were they C5, C6 and the ventral and dorsal division and the two nerves arising from the upper trunk, which are the suprascapular nerve and nerve to subclavius. I'm just telling you. Yeah. Movement possible. It's a all the three dimension movements are possible. This is flexion, extension, adduction, abduction, medial rotation, lateral rotation, and circumduction are possible in the shoulder joint. Let's see now what muscle causes what. Clavicle head of the pectoralis major, these fibers, clavicle head of the pectoralis major causes the flexion, along with the anterior fibers of the deltoid. Then the weak flexors are the coracobrachialis, along with the biceps. Posterior fibers of the deltoid and teres major. This is the teres major and this is the posterior fibers of this one. This is the posterior fibers of the deltoid causing the extension. So just remember anterior fibers of the deltoid causes flexion and medial rotation along with adduction. The posterior fibers of the deltoid causes the extension, lateral rotation along with the adduction. Whereas the middle fibers of the deltoid, that means acromial fibers of the deltoid causes the abduction. Remember, okay? Adduction. So anterior fibers of the deltoid, pectoralis major, teres major. These are three people petralis major, teres major, and latissimus dorsi. These three people you have seen on the lateral lip, medial lip, and the floor of the bicipital groove. They are adductors and medial rotators. These three people, petralis major, teres major, and latissimus dorsi, are adductors plus medial rotators. Okay, along with anterior fibers of the deltoid, coracobrachialis, and long head of the triceps. Abduction. Abduction is a lengthier process. The initiation of the abduction is done by the supraspinatus muscle. Around 0 to 18 degree is done by the contraction of the supraspinatus muscle. Further, from 18 to 90 degree, 90 degree is done by the acromial fibers of the deltoid. Acromial fibers of the deltoid is multi-pinnate nerve fibers. That means maximum number of nerve the muscle fibers are accommodated in the limited available space. So the force of contraction will be maximum. Okay. Then from 90 to 180 degree is done by the upper and lower fibers of the trapezius along with the serratus anterior. Remember here, these two people, the serratus anterior and trapezius, not acting on the shoulder joint. It is acting on the joints of the pectoral girdle. That means it causing the rotation of the scapula. That means when you're raising your arm to such a way that your arm is rubbing against your earlobe, that is called overhead abduction. From 90 degree, you're raising your arm so that your arm now is parallel with your head and neck, or your arm is rubbing against your earlobe. That condition, the glenoid cavity is exactly directed upward. In normal condition, you can see it's directed laterally, backwards, and upward. But when the overhead abduction, what is happening? The inferior angle, this area, inferior angle of the scapula rotates laterally this way so that glenoid cavity become directly directed upward. Okay, the glenoid cavity is directed upward, exactly upward. This is going laterally and this go medially so that glenoid cavity is directed upward. Clear? This is caused by the upper and lower fibers of the trapezius and serratus anterior together. That causes the rotation, lateral rotation or outward rotation of the scapula done by these two muscles. They are not acting on the shoulder joint, remember. So I told you around the 180 degree, 120 degree is happening due to the abduction of the humerus in the shoulder joint, whereas the remaining 60 degrees happening due to the movement of the rotation of the scapula in the acromioclavicular and the sternoclavicular joints. Medial rotation, the petralis major, teres major, and latissimus dorsi, the people in the bicipital groove with anterior fibers of the deltoid and subscapularis. Lateral rotators are the small muscles infraspinatus and teres minor. Infraspinatus, this is infraspinatus, and the teres minor are the muscles which are shorter in length compared to other muscles. So since it is a very unstable joint, and disproportionate size of the head of the humerus and the glenoid cavity, there is a chance that head of the humerus can dislocate mostly to downwards. When the abduction happens, up to 90 degree, no issues. In 90 degree, what happens? There's a chance that head of the humerus may slip down. That will be prevented by the three small muscles which act in synergically when the middle fibers of the deltoid causes the abduction of the humerus upward. The three muscle, what are they? The infraspinatus teres minor and subscapularis. Infraspinatus teres minor and subscapularis act together to keep the head of the humerus in close contact with the glenoid cavity. Okay. Again, the when the abduction happens above 90 degree, the greater tubercle of the greater tubercle of the head of the humerus go and rub against the acromion process. They impinge under the acromion process that prevent the further dislocation, further abduction. Sorry, when the when the abduction happens beyond 90 degree, the greater tubercle of the humerus go underneath the acromion process and it prevents the further abduction of the shoulder joint. So at that time, the lateral rotation of the humerus is essential. That means your infraspinatus and teres minor together causes the lateral rotation of the upper end of the humerus so that it clears off the acromion process. So the no more on further abduction, the greater tubercle go and rub against the acromion process. Okay. So here in abduction, apart from the prime movers, the subscapularis, infraspinatus, and the teres infraspinal teres minor and the subscapularis act as a group and prevent the separation of the head of the humerus from the glenoid cavity. One. Another stage, on further abduction beyond 90 degree, the rubbing of the greater tubercle against the acromion process is prevented by the lateral rotation of the humerus by the action of the infraspinatus and teres minor. So if this simply descend downward, it is called as the subglenoid. This here we can see from the normal position, it slips down to form the subglenoid or come a bit more anteriorly and it is called becomes subcoracoidal position or more medially to form the subclavicular position. This causes the traction of the axillary nerve and causes the injury of the axillary nerve. What happens? The injury of the axillary nerve, the shortening, the flattening of the shoulder happens and the abduction of the humerus become impossible because it supplies the deltoid. Frozen shoulder is the tendinitis of the rotator cuff. Okay, and painful arch syndrome means thickening of the supraspinatus tendon so that patient feel pain between 60 to 120 degree of abduction because of the the supraspinatus tendon is thickened and is going to rub against here, making the abduction painful. That's all for the time being. Hope you understood. Please give me the feedback in the comment section. Thank you so much.